Hello everyone, in this video we are going to see how to manage a case of organophosphorus poisoning. This is more common than you think because usually I used to get at least one case during my working hours in casualty. That's why you should know how to manage a case of OP poisoning. This organophosphorus, this is insecticide. That's why this is usually available in our households. Common agent for both suicide as well as homicide. These OP compounds, these inhibit the enzyme that is acetylcholine esterase and causes the accumulation of acetylcholine. Consider whenever there is a release of acetylcholine from the nerve endings, it usually goes and binds to the receptors present over the other ending. But whenever its action is over, there exists an enzyme to degrade this, that is acetylcholine esterase. Okay, this acetylcholine esterase actually got two parts. One that is esteric part and the anionic part. Anionic part and esteric site. Okay, but during this OP poisoning, the organophosphorus compound, mainly the phosphorus component, will bind to the esteric site irreversibly. This irreversible binding causes the inhibition of the enzyme, inhibition of the acetylcholine esterase enzyme. That's why whenever there is inhibition, there is increased acetylcholine accumulation at the nerve ending. This causes exaggerated response of the acetylcholine. That's why usually we know that this acetylcholine is a parasympathomimetic. Let's see what are the effects of OP compound. It has got nicotinic effect, muscarinic effects, CNS effects because it crosses the blood-brain barrier, and nicotinic after effects. Okay, what are the nicotinic effects? There occurs the muscle weakness, fasciculations and convulsions, hypertension and tachycardia. And muscarinic effects are the pinpoint pupils, salivation, sweating, cold limbs, bronchial secretion with rales, bradycardia, and diarrhea. As I already mentioned you, this is the parasympathomimetic. Okay, that's why there is pinpoint pupil and excessive salivation, as well as bronchial secretions are increased. Whenever there is increase in bronchial secretion, that's why there occurs the rales sound. Okay, and CNS effects are anxiety, restlessness, and that is organophosphorus induced delayed polyneuropathy, that is OPIDP, and nicotinic after effects. This is also called as intermediate syndrome. Okay, this usually occurs after 2 to 4 days of the OP poisoning, and there occurs the death because of respiratory muscle paralysis. Whenever you admit OP poisoning patient, you should make sure that you admit for 3-4 days so that you should rule out the intermediate syndrome that is about to happen. We will straightly go into the treatment part without wasting much of our time. Okay, whenever a patient comes with a OP poisoning, what are the things you must ask? Okay, the first thing, that is history. Whenever you ask history, you should ask which is the compound. Most of them they will say it's an insecticide. If possible, ask them to bring or show the insecticide bottle. Okay, insecticide bottle. There are two reasons. One thing, he will confirm whether it is an OP compound or not. And one more thing, even though it is not an OP compound, there usually one line exists saying which is the antidote for the accidental or poisoning of the uh, which is the antidote for the compound that exists. Okay, usually it is OP OP compound, the antidote will be written as atropine. Okay, atropine sulfate. That's why you should always ask them to bring the bottle, or at least you should ask them send the photo of complete bottle. Let's get to the treatment part. Mainly this is airway, breathing and circulation. So you should always clear the airway, attach the pulse oximeter to know the oxygen saturation level and provide oxygen if it's low. And meanwhile insert large bore Riles tube of number 22 to 24 in number for stomach wash, and you should wash till it gets clear. Okay, till you get the clear fluid, you must wash the stomach. After that, if there is absence of gag reflex, then don't forget to intubate the person. Okay, and remove the contaminated cloths. Wash the contaminated skin with soap and water. Wash the eyes with normal saline. See, this OP compound, it will get absorbed to lungs as well as skin. That's why your personal protection is also very important. And this is a irritant to the eye. So always whenever a person comes with a opioid poisoning, you must do these things. Usually we forget in our urgency, but we should not do that. Okay, we should remove the contaminated cloths, wash the skin with soap and water, and wash the eyes with a normal saline. If he is unconscious, then put them in left lateral position. Then comes to the next part, that is injection atropine 5 ampoules, which contains 3 mg IV loading dose, then 5 ampoules for every 10 minutes till the patient is atropinized. I will tell what is atropinization. Then when you complete the dose of 10 ampoules, then 2 ampoules every hour till the atropinization. Okay, then then you should give injection prolidaxime, which is oxime compound. Okay, I will tell what is this oxime. 2 ampoules which contains 2 gram. You can give prolidaxime 1 to 2 grams. Okay, 1 to 2 grams, that is IV stat. Then 2 ampoules hourly. Total in 24 hours you can give 10 ampoules. Then 2 ampoules every day till recovery of the patient, and maximum you can give up to 8 days. Okay, this oximes, this will bind to the anionic site of the acetylcholinesterase. Here this is OP, that is bound to esteric site. This oxime will come and bind here. This oxime will react with the OP compound and it will make the acetylcholinesterase. These both compounds will detach. Okay, after detach they will make this acetylcholinesterase free. So this free form of acetylcholinesterase will help in degrading the acetylcholine that is accumulated over the synapse. Okay, this is the mainstay of the treatment. Okay, I will repeat here. 5 ampoules of atropine loading dose, then 5 ampoules for every 10 minutes, then 2 ampoules every hour till atropinization is achieved. Then injection prolidaxime. These are the oximes. It's better to give oximes earlier, but you should not forget that atropine is the mainstay of the treatment. Okay, the oximes should give 2 ampoules stat, then 2 ampoules hourly. Maximum you can give 10 ampoules in 24 hours, then 2 ampoules every day till the recovery. And you must not forget to add one antibiotic. So you should add injection zone, that is ceftriaxone 1 gram IV for 8 hourly. Then you should repeat the dose. Okay, and you should not forget to stomach wash the person. You should constantly giving the stomach wash for the patient. Atropinization is very important because to know whether atropine overdose is happening or not. Okay, so by the time you achieve atropinization, it helps us to detect clinically that the person is recovering, kind of recovering from the OP poisoning. Okay, so how to detect? Whenever there is pulse rate more than 110 and less than 150 beats per minute, blood pressure, systolic blood pressure more than 80 mm of Hg, and the pupils dilated more than 75%, sweating stops, limbs become warm, basal rails should reduce or disappear. And when you exactly tell atropine overdose happened, when there is more than 150 beats per minute pulse rate and pupils becomes fully dilated and patient becomes violent. This is the atropine overdose. Whenever there is overdose, you must stop the atropine, then again you must start the atropine once again. So whenever there is specific condition, you should try this. Okay, if there is hyperkalemia, that is more than 5 milliequivalents of potassium, then you should give injection calcium gluconate 10 ml slow IV stat and salbutamol nebulization stat, that is 10 milligram in 4 ml over 10 minutes, and also glucose insulin drip if the potassium level is more than 7 milliequivalents per liter. And if there is convulsions, then you should give injection diazepam 2 ml IV stat, then injection phenytoin 500 mg in 10 minutes. And also you can give phenobarbital and levetiracetam. Phenobarbital at the dose of 15 milligrams per kg over 900 milligrams slow IV, and levetiracetam 20 to 30 mg per kg IV slow over 5 minutes. Maximum dose you can give is 3 grams for levetiracetam. Whenever the patient becomes violent, it's mainly due to atropinization. That's why we must stop the atropine temporarily, and we must give injection diazepam 2 ml that contains 10 mg IV stat. Then haloperidol 5 mg either IM or IV. Okay, haloperidol IM or IV. Or else you can also try injection chlorpromazine, and injection, this is for violency. And if the person gets fever, usually mainly because of the fasciculations and all, the patient might get fever. For at that time you can use paracetamol 1 ampule IV. If there is respiratory difficulty or palsy, SpO2 less than 80%, in spite of giving the oxygen or continuous convulsions, then intubate the person and put him on mechanical ventilation, and can be maintained for 2 to 15 days. And you can use excellent choline for the intubation and provide him the muscle relaxant. Keep the patient continuously atropinized and maintain his blood pressure. When the patient starts breathing effects, gradually wean and extubate the person. Some of the important points. Atropine may also be given by syringe pump after initial loading dose of 5 ampoules. Okay, it will be helpful in pediatric patient. Atropine is available as 30 ml and 100 ml vials. Okay, then you can use at 10 ml per hour for 2 hours, then 5 ml per hour till atropinization through syringe pump, then reduce and adjust the dose. Okay, 20% of the total dose is required for the atropinization per hour. You can also use glycopyrrolate instead of atropine with equal effect. The dose is 100 microgram bolus every 5 minutes till the atropinization is achieved. Collect the first stomach wash sample for forensic lab analysis and to be handed over to the police. As you know, this OP poisoning is a MLC case, that is medical legal case. That's why it becomes important for us to give this sample to the police. Usually we won't practice this, but you can practice. Okay. Also, if available, ask the relatives to bring the poison container. Already I told you about this, and it's better to ask them to bring the can that the patient consumed. Organocarbamates such as carbofuran carbaryl, trimethocarb, phenocarb, etc. have a shorter duration of action, and because of its shorter duration, it will respond to the treatment very good. Lipophilic compounds such as disulfophane, phentoin have delayed and prolonged action. So organocolloids such as endosulfine, DDT, methoxychlore, chlordane, benzene, endrine, etc. have CNS stimulation and convulsions might occur. I already told you we should give injection diazepam. And intermediate syndrome is more common with the parathion, methylparathion, and dichlorowas. So how to prevent accidental poisoning? In suicidal, homicidal, it's difficult to avoid, but for we can avoid at least accidental poisoning. Okay, use protective clothing and mask while spraying insecticides. Bath after work to wash all the pesticides deposited on the skin because it will get absorbed through the skin, and extremely toxic organophosphate should be banned. Okay, and you should store the insecticides away from the children because they won't understand it's a insecticide. So this is all about OP poisoning. Long video. So this is all about OP poisoning. If you have any doubt, please comment them down. We'll see you next.